Welcome to GEMCast, the Geriatric Emergency Medicine podcast, where we discuss important topics in the care of older patients in the emergency department. I'm your host, Christina Shenby. GEMCast is produced with the Geriatric ED Collaborative. You can find more episodes on any podcasting app, and you can find the show notes on the resources page of gedcollaborative.com. Welcome back to GEMCast. Hi, everyone. I'm Christina Shenby, and I am joined by a return GEMCast guest, Dr. Danya Khoujah. Thank you for being here, Danya.
Thank you for having me.
And we are going to talk about an important paper here, which is the very first clinical practice guidelines of the Geriatric ED Guidelines 2.0. So first of all, Danya, tell us about why this is important and why these guidelines are being put out. They are a big lift from a lot of people, so there must be something very important about them. Tell us what that is.
Well, thank you for creating a platform for us to talk more about these guidelines. And you're absolutely right. They are a really big deal. This is the first in our series of the guidelines of the Geriatric Emergency Department Guidelines 2.0. Now, this one discusses delirium, but of course, there's a lot of other topics that we're going to discuss. And it is a grade-based guideline, and we'll talk about that a little bit more. And it's been in the making for 5 years with so many people involved. The first part that makes this exciting is that it's delirium. And I like to talk about delirium. I think it's important. I think we miss it. I think there's so much room for improvement. So there's that part. But the other part is the grade methodology that's really exciting about this. The reason this is unique, without getting into like the nitty-gritty details about research, is that these guidelines don't just look at the level of evidence, like does something work or does something not work, and then use that as the sole determinant of whether we should recommend something. It considers things like feasibility, acceptability to the patients and the healthcare workers, to the costs, both time costs, financial costs, any other less tangible costs. And that makes the product much more comprehensive and realistic. Another key strength for this is the diversity of the work group. Just like you said, it was a heavy lift by a lot of people, but it's a lot of people from different parts of the world, different parts of the country in the US, and different practice settings. So people who work in academic settings, rural settings, community settings. And therefore, these guidelines are a lot more applicable because they've had individuals from different parts of their practice look at them and say, does this make sense?
And if you are not familiar with the grade methodology, that stands for grading of recommendations, assessment, development, and evaluation. And this is kind of the gold standard for creating clinical practice guidelines. So all very important that this has been done incredibly rigorously with a lot of attention to detail, looking through the literature and asking first, what are the important questions that we need to know about delirium? And second, what does the evidence say? Third, how good is that evidence? And four, is this feasible in the real world? So let's talk about first, what are the questions that the group asked about delirium?
Well, the writing group selected 3 key questions about delirium. The first is delirium risk stratification. The second is delirium diagnostic tools. And the third was brain imaging and delirium.
Great. And just for a little background, in case you're brand new to GEMCast and we have not spoken before about delirium with you, dear listener, delirium we can think about as an acute change with altered mental status. And if you want the official DSM-5 criteria, that is going to be a disturbance in attention that develops over a short period of time, usually hours to days, with can have an additional disturbance in cognition, things like disorientation, language, perception, and it's not better explained by some pre-existing or established neurocognitive disorder. So this is not, there's a pre-existing schizophrenia or something like that. And typically there's evidence from the history, physical and exam, labs, etc., that the disturbances in attention and awareness are due to some sort of medical condition or multiple etiologies. And I will say most often it's multifactorial. So that's just a quick get you up to speed on delirium. And the questions, as Danya mentioned, that the group asked were one, can we figure out who is at highest risk for delirium? Yes, you could screen everyone for delirium, and some places do, and that's a great option. But maybe instead we can identify who's at highest risk and then focus our attention there. And then how can we diagnose it in the ED? And then do people with delirium need a head CT? Very practical questions. Let's start with that first one, the delirium risk stratification tools. What are the tools out there and how good are they?
So, just like you said, Christina, we need to figure out, are there methods where we can identify a subset of older adults in the ED that are at high risk of delirium? So, we should screen them, or the opposite, that are low risk of delirium. So, we should not really be trying to look for delirium in that group. And the goal is to figure out how can we consolidate our efforts in a way that's feasible. Because although we all know that delirium exists and delirium is important, reality is we miss delirium a lot, at least half the time. And that's like in the really good studies that make us sound really good. In some studies, we miss it around 85% of the time. So, kind of doing what we're doing right now doesn't work. And therefore, we need to be a little more vigilant and look for it. Sort of the same idea where we think of like pulmonary embolism, right? We know pulmonary embolism is there. We need to look for it, but we're not going to CT everybody who comes in with anything remotely like a pulmonary embolism. That just doesn't make sense. We need to figure out the risk stratification, and we have tools that we're familiar with for that. And then we figure out, do they need further workup? Do they need that CT? In this case, we do these delirium risk stratification tools. If the person is high risk for delirium, then we go ahead and do those diagnostic tools in an attempt to consolidate and focus our efforts on individuals that really need it.
That's a great parallel to pulmonary emboli, where yes, we don't want to do a D dimer or a CT scan on everyone, but we can use things like PERC or Wells criteria to say, okay, they're low risk Wells, and that in my documentation implies I'm not pursuing further workup on this. And it's things that are relatively easy to determine, like have they had a history of a DVT or PE? Do they have cancer, et cetera, et cetera? So it's things that are relatively easy to access. And that's a key point because if figuring out whether they have a high risk for delirium takes just as much time as screening for delirium, then you've wasted more time. So the things that go into the risk stratification need to be quick, readily available. So talk us through the different scores and what they include.
So the first one that the guidelines looked at was the delirium risk score. And basically, they said we can use that to identify the subset of older adults that are at low risk of delirium. What that means, if they're meeting the criteria in this risk score, therefore, we don't need to look for this further. The score includes things, just like you said, that are readily available. Do they have a history of dementia? Do they have functional dependence, right? Where if you want to formalize that, they looked specifically at the CATS activities of daily living. They were able to do 4 or less on the score for that one. Are they hearing impaired? 3 simple things. If they had none of these 3, then they're considered low risk, and we were done.
So to recap, these 3, do they have dementia, difficulty with their activities of daily living, and hearing impairment? And those 3, and these come from some earlier studies by Jin Han and his group, where if you had all 3 of those, almost 50% of those people in the ED had delirium. Whereas if you have none of those, then less than 1% have delirium. So I would draw an analogy here to the PERC, the pulmonary embolism risk criteria, that, if you are PERC negative, then you're very low risk. You're ruling it out. So if you are negative for all these 3 things, very, very low risk of delirium. Now, the devil here is a little bit in the details, as always, where the devils like to hide, which is this functional dependence aspect. And even the dementia one, if somebody has really severe dementia, it's typically somewhere in their chart. But some mild to moderate cognitive impairment, it may not be known or it may not be in their chart, depending on their level of engagement with the healthcare system. And then functional dependence or difficulty with your activities of daily living, there's a formal score for this, like there's a score for everything, your cat's activities of daily living, but that's not something that your triage nurse is going to do. Probably they're relying more on their gestalt of can this person do their activities of daily living? What are your thoughts on that aspect, Danya?
I mean, I think that in a perfect world, which we all aim to be in, that your cat's index of independence and the activities of daily living or other formalized assessment of the person's ability or the person's need for help for these activities is part of your nursing assessment in triage, right? So again, in the perfect world, we're looking for this actively and we're asking these questions. But I think that even if you ask a simple question and say, hey, do you need help with your activities of daily living? That can be a segue to answer that question. Again, just to be super clear, there are no like validated studies that compare asking this one question with the CATS index, specifically when it comes to the Delirium risk score. But the whole idea, just like you said, Christina, is that how can we take this evidence to inform our practice in a way that's practical?
Mm-hmm.
And basically, what this tells me, kind of looking at this recommendation, is that if I, as the individual, not as the emergency department director who's coming up with a protocol, right? But as the person, if I'm seeing somebody and I'm like, they have no dementia, like as their physician, right? They don't have dementia, they don't have dependence, and they don't have hearing impairment, then I'm not spending time on step number two, which is my diagnostic tool.
Mm-hmm. Mm-hmm. Yeah, and I think there's a couple useful lenses to look at this from. One is for the individual emergency physician, APP working in the ED. If you start to notice, oh, this patient has dementia, and oh, I'm having to like get right next to the bed to speak because they can't hear me. Whenever that happens to me, whenever I have to really shout to have someone hear because of their hearing impairment, an alarm bell goes off in my head that this person is scoring positive on the delirium triage risk. Or often, yes, you can ask them, like, do you need help getting dressed or getting food or, getting around? And often you can somewhat tell just through interacting with them. So for the individual clinician, I think this is very useful for helping you gauge how worried should I be that this person either has delirium walking in the door or could develop delirium when they get during their ED stay. So that's another important distinction of prevalent versus incident delirium. So prevalent delirium is somebody comes in the door with it, and incident delirium is it occurs while they are in the ED or boarding, etc. So from the individual clinician standpoint, I think it's useful. Then let's say you are taking the lens of a medical director, deciding should we hardwire this into all of our triage nursing assessments, which is a big deal. You do not do that lightly because your triage nurses are very, very busy and will not like you if you are putting a lot of things in that don't have an actual benefit and an actual what next. So I think that this one is reasonable to consider implementing into your triage screen, or maybe it's your bedside nurse screen, depending on your workflow, etc. So to summarize, Delirium risk stratification tool can tell you who is low risk. If they're low risk, they score 0 out of 3 for those things, then you don't need to go to the next step of doing a formalized delirium assessment. So that's the first one. What are the other recommendations in terms of just risk stratification?
So the second one was related to something called the Zucchelli's risk assessment tool. And specifically, the studies for that came from OBS units in the emergency department. And that's why our recommendation is specific to that. If you have an OBS unit in your ED, you can use Zucchelli's risk assessment tool to identify patients at low or high risk and decide whether further testing is needed. Zucchelli's has a little more options or a little more factors than your delirium risk score. So with Zucchelli's risk tool, it includes 4 elements: age 75 or above, dementia, hearing impairment, and the use of psychotropic drugs. And it's important to note that they're not all weighted equally. So you got to take a look at that and make sure you're calculating it correctly. A score of 4 or more is considered positive, so high risk for delirium. And those are the ones that you'd want to use a delirium diagnostic tool and figure the next steps out.
Okay, so far we have the delirium risk stratification to screen for delirium risk, the Zuchelli's for patients going to an OBS unit, and then what's the third one?
Well, there's the REDEEM score. That specifically is for adults over age 75 coming into the emergency department. And you have a couple of cutoff numbers here. The threshold risk of 11 can identify those that are low risk or high risk. And if you want to be even more sensitive, you can use the lower cutoff of 5 and use that to rule out those that are high risk and therefore screen everybody else who's not 5.
So, and my understanding is the Redeem tool aims to be mostly an EMR based tool that can give you the risk. What are the components that go into it?
So I think that the goal, and we can talk a little bit more about that, is that all of these can be chart based so that we can
Yes.
offload our triage nurses and allow this to happen in the background. Because just like you said earlier, which was so on point, Christina, if the screening is going to take as long as the diagnosing, then it's kind of pointless, right? So that is why. But yes, you're right. With Redeem, a lot of the elements are a lot simpler to pull from the charts. So things like arrival via ambulance, if the triage chief complaint is altered mental status, if their O2 status is low, if their blood pressure or respiratory rate are too high or too low. If while the nurses were doing their fall risk assessment, they noticed that the patient has confusion or altered elimination, then that would count as risk factors. And then a history of seizure disorder. Now, all of those would contribute to these points. The one thing that would kind of detract from these points are if they come in with an ESI level of 3 or more. So, they're not as sick. Now, if the score is 11 or more, it's considered positive. So those are high risk. If they're less than 11, then it's considered negative. And like I said, you can use it at a different threshold as well, with 5 being your threshold and using that to figure out who's negative and add a little more sensitivity to your tool.
So, with all of these, as you said, the goal would be for the information to be in the chart. Some AI bot in the background harvests the information and gives us on a platter, here is your delirium risk score. However, that requires that our little AI bot can go and find the information that it needs to harvest. And with many of the things, it probably can. Dementia, hopefully, is on the chart. Hearing impairment, maybe on the chart. Difficulty with ADLs, I don't know how often that is going to be on the chart or not. And then my issue or challenge with the redeem score is this little component that it puts in here that is you need to do a fall risk assessment. Now, that is not always going to be in the chart, especially not acutely. Maybe they had a fall risk assessment 3 years ago when they were in the hospital. And during the fall risk assessment, the nurse is supposed to also document, do they have difficulty with elimination? Now, I will just say in my ED, I don't think that I know that there is not a routine fall risk assessment in which the nurses are asking about altered elimination. So maybe you would have to make an argument that that needs to be implemented and then documented. But as it stands in my EMR, at least, my AI bot would not be able to go and retrieve this information because it's not readily available in the chart. So I think those are just factors that, again, if you were putting on a medical director hat and thinking about what do we implement, you would have to get into the weeds with the tools and see which tools have components that are readily available in your EMR. So let's come back
Great
to
points.
how do we first, what do we see as the impact of implementing these risk stratification tools?
So the idea is that here we're trying to improve our detection of delirium because so far we do a terrible job. And if what we're trying to do here is to improve it, then saying that we're going to try to run the diagnostic tools on all of our older adults, it's just not going to work. It's way too much work. So if we implement this either at the triage level, at the bedside nurse level, or even on an individual level, just like you said, for the delirium risk score, I'm like, hey, do they have dementia? Do they need help with their activities of daily living? Can they hear me? And if we're having issues with any of these 3, then I'm like, Let me take an extra second here and do step number two, which we'll talk about right now. And kind of to put this into numbers and make this a little more real of how great it would be if we can actually implement one of those risk stratification tools early on in our visit so that we can keep an eye out for delirium, is that, for example, with the REDEEM score, during their own derivation study, when they used a score of 11 or more and said, okay, well, we're just going to identify those as high risk for delirium, therefore, those are the ones that we're going to need to use diagnostic tools for, then the testing burden decreased by around 80% because of their whole population, only 20% of it scored positive with that, higher threshold of 11. So if you're thinking about that for your older adults in your emergency department, you see 100 older adults every day. You just have to run your tools on 20 of them because you just excluded 80 from your pool. Again, is this perfect? No. Are we going to miss a little bit of delirium? Yes. But it is so much better than when we are right now because where we are, we're missing the majority of people. If you were to ask people to do something, it has to be realistic. When you're asking people to test their older adults for delirium, ask them to test 20 a day, very different than asking them to test 100 a day.
Yeah, that's a great point. And similarly, Mayo Clinic in their inpatient wards, they have developed, and this is published, they've developed an AI-based or, basically EMR-based screening score that does this risk stratification. And then the nurses only do formal delirium diagnostic tools on patients who are at high risk. So everything we've talked about so far is just trying to risk stratify to say who is high risk and who is low risk. And then for the people who are high risk, now we can use an actual instrument to formally diagnose the delirium. So what did the clinical practice guidelines give as recommendations for what we should use for that second step?
So for our delirium diagnostic tools, the question was, can delirium screening instruments accurately rule in or rule out delirium? And we came up with two recommendations. The first was that we can use a whole bunch of tools to rule delirium in or out. And those are the 4AT, the BCAM, CAM-ICU, and MCAM, very similar to each other, the AMT4, and the RAS score. Those are tools that are, again, very simple and they are adequately sensitive and specific enough to diagnose delirium.
So all of these have, again, their own list of questions, their own ins and outs. I would say if you're interested in implementing something like this, the two that have been, at least to my knowledge, best studied and most implemented in the ED are the 4AT and the BCAM. And those are both quick, relatively quick things that can be done in the ED and by the bedside nurse or the triage nurse or whomever to then say, okay, this person, first of all, with our other tools, is high risk for delirium. And now let's use the 4AT or the BCAM to actually diagnose it. If you're not familiar with these tools, I won't go through all of them, but the BCAM and the 4AT have the best levels of evidence in the ED. And the components for the BCAM, this stands for Brief Confusion Assessment Method, there's four core features. It's kind of three with a bonus. One, do they have altered mental status or fluctuating course? Two, do they have inattention? And three, do they have altered level of consciousness or disorganized thinking? And there are specific things that you can ask them to help elicit this disorganized thinking. And then the 4AT has four domains, as the name would suggest. One, and you get different points for them. So one is alertness, whether they're, drowsy versus more agitated or hypervigilant. And then two is kind of a screen within a screen. It's the abbreviated mental test where you ask them orientation questions. So their age, date of birth, where they are, the year, etc., and then score them for mistakes. And then attention is the third one. This is things like having them give the months of the year backwards. And then the fourth component is acute change or fluctuating course. So you get points for each of those. And then if it's 0, delirium is unlikely. If it's 1 to 3, then it's possible cognitive impairment, four or more possible delirium with or without dementia. So those are the components, can be easily put into your EMR and assessed at triage. Okay, diving back in. Were there any other recommendations?
So the second recommendation had to do with using the delirium triage screen. And the recommendation is that we may use it to rule out delirium, so not to rule it in. Basically, we're saying it's quite sensitive, but it's not specific enough.
Yes, and the delirium triage screen, again, is a quick, meant to be used at triage, a quick thing where you look at do they have altered level of consciousness and do they have inattention? So you could say spell lunch or spell world backwards, and that is relatively quick. And the DTS, the delirium triage screen, is often used in concert with the BCAM. That's a common two-step thing, but good to know, good to remember. The DTS can rule it out, but not rule it in.
Yeah. That said, with all these screens and tools, just like you said, we need to familiarize ourselves with one of them, a couple of them, and use that. And the idea is, even if something is not perfect, it needs to be doable for it to actually happen, right? And that's why these tools, we looked into it, one of them was a cost, right? And people are like, well, what's a cost? It's a tool, time. Time is very, very expensive. And mapping the time shows you how expensive that could be if you want to use this on every single older adult. And many of these tools take less than 3 to 5 minutes. And in all reality, the RAS or the AMT4 take less than 1 minute. So if you're thinking about this, if we have in a perfect world, if we have these risk stratification tools on the level of the electronic health record, again, whether it's in triage or right when they get to the room, not perfect, but at least it's there. And now instead of us having to do this cumbersome long thing for 100 people, we are doing it for 20% of them, for 20 people. But it's not this long, cumbersome thing. It's these tools that take less than a minute.
Mm-hmm.
So it is not that cumbersome if we know what we're trying to do
Mm-hmm.
and we can actually select our population well and select our tools well.
And I think, the key will really be also using the EMR well, being able to harvest data that's there so you don't have to do as much in-person time because time is costly. We don't have a lot of time. The other key thing is that we're doing all this work to risk stratify and then diagnose delirium. That only really matters if we do something with that information. So if we know that if we identify that somebody is at high risk for delirium, maybe they don't have delirium right now, but they're high risk. And this was not really addressed in the paper. This is a separate question, but then you have to think about, well, what do we do for that patient? Or maybe we identify they have delirium. What do we do for that patient? And a few of the answers are first, for those patients who are high risk but don't have delirium, try to not let them get delirium, which is something we've talked about before on GEMCast and is not an easy fix because it's not just one stimulus and one response. It is a whole lot of things, a whole host of things to try to maintain homeostasis, hydration, sleep wake cycles, noise, orientation, comfort, getting to the restroom or having a bedside commode, all of those little things that can help prevent the delirium developing. Or policy-based things, patients who are at high risk or who have delirium, you might consider making a protocol that prioritizes them for bed placement. In our era of limited inpatient bed capacity and ED boarding, those patients are at much higher risk for worsening if they are in the ED. We also know every hour spent in the ED holds a 2% increased risk for delirium for vulnerable patients. So it's important to then ask, well, what are we doing with this information? Which leads us to the last question, which is, well, if they have delirium, do I need to get a head CT? What do the guidelines tell us about that?
Before I talk about that, I just want to say that those are great points that you made, Christina, is that we don't necessarily have to think of these guidelines that we just talked about with these recommendations in like a linear fashion, like, oh, you just have to use the delirium risk stratification tools to figure out who to diagnose, but also, just like you said, to prioritize the rest of our care aspects, whether we're talking about bed placement, whether we're talking about interventions, like what is it that we're doing for them? Because again, in all reality, we'd love, love, love to be able to take care of all of our older adults in the best way possible. But sometimes we just can't. And prioritizing the ones that are more vulnerable may be the way to start, at least. So, talking about head CTs, unfortunately, the recommendation was unable to come up with something because we had insufficient data to recommend for or against head CT in undifferentiated older adults with delirium or altered mental status. And the reason is that data just does not exist. Like when we even try to do the systematic review and look at the original studies to come up with something, we could not even find enough studies or any studies in the ED where people had the diagnosis of delirium per se, and then they had the head CT done to the ones with delirium, ones without delirium, and so on. And therefore, we had to use like this big generic diagnosis of altered mental status as a kind of all-encompassing diagnosis, which again is not the same as delirium, but it was a surrogate here. And we looked at all those patients and so on. And there's just not data. What the data told us is that somebody with focal neurological deficits is a lot more likely to have an abnormal CT, but we really didn't need this study to tell us that, right? I think that
Right.
everybody here knows
Yeah.
that if somebody, yeah. So nothing groundbreaking here. We proposed actually also looking like anticoagulants as a predictor for an abnormal CT. The data was not there. It wasn't more likely or more of a predictor of an abnormal CT. And then we also thought about headache, but there just were no sufficient studies that looked at that. So sorry to disappoint everybody that we don't have an answer. But here is what was actually really funny. It's not like you can kind of possibly read it in like in between the lines. So when we started the study, our goal was to decrease how often we do head CTs, right? Because the general sentiment is that we do way too many. And if you look at the data, depending on what exact practice pattern they have and the location of that ED and so on, in some of them, around like one third to one half of the patients that are coming in with delirium end up getting a head CT, which exactly,
That's a
we
lot.
all thought that was exactly, that's a lot because we think, that's just too much. And that is what we wanted to be clear here is that we're not trying to say, please go ahead and CT everybody because we don't know who needs a CT. Our sentiment is, since we don't know who we need to CT and it doesn't look like CT is something we need to recommend for, perhaps we need to start decreasing our current CTs because the current practice patterns overall is that we over CT
Mm.
people. The problem is that we don't have a clear answer for how much
Yeah. And
are we
who
over
does need a
CTing
head
them.
CT? Who is high risk? So,
Correct.
what's your personal practice? Say you have an older patient with delirium. Which patients would you CT versus not CT?
So I would say, and that was impossible with the data that we had to put as a research question. What we wanted to ask was, in those patients who you could not find any other cause in, should you do a head CT? To me, that would be the perfect research question.
Yeah,
But again,
exactly.
there's no research study that actually answers that.
Yeah.
Unless, one of our listeners wants to create that, we would love, love, love you for this. But that's my practice, right? And that's, I think, the question that we tend to think of as people who are invested in geriatric emergency medicine is how can we decrease these CTs? And who do we CT? And the answer is, unless they have, obviously, we're not talking here about your trauma patient who's coming in with
Hmm.
altered mental status, right? If I have a really clear reason or reasons, as you alluded to before about delirium being multifactorial, if I don't have a reason at all,
Mm.
then you may be the one that I would do a head CT on.
Hmm. Hmm. That makes total sense. Yeah. If you come in with urosepsis and you're altered with, we diagnose delirium, we have a pretty good cause. You have urosepsis. Or, if you have some pharmacologic toxicity or side effects, we have a good reason. But it is difficult in those patients in whom we haven't found a good reason. All the electrolytes are normal, there's no signs of infection, then it gets a little bit more challenging.
Yeah. And another part of this, or another aspect or element that we looked at for this, As you remember earlier, we're talking about like with the great methodology, we need to look at acceptability, right? We need
Mm,
to look at the cost to the individual, to the system. And with HET CTs, this is not just about the actual cost of the actual HET CT itself,
hmm
but let's take a moment and think about our confused older adult who's not cooperative.
mm.
Trying to get those into a CT is so challenging and so costly to them in the sense of, do we have to restrain them? Do they have to be medicated?
Yeah.
And are we open? And are we actually creating more problems with these two things? And the answer is usually yes, right?
Mm.
Are we increasing the risk for badness, for delirium, for worsening delirium, and so on and so forth? So, again, the question here, getting a HET CT is not just about, you paid for the HET CT and you put a person in a scanner and they got a little bit of radiation. In some of our older adults, it's a lot more of a big deal. And that's
Mhm.
why it was really hard to answer this question and say whether HET CTs are needed because you're talking about a very varied spectrum of older adults.
Mm. Great points. So we've gone through the three questions that these clinical practice guidelines sought to answer of how do we identify who is high risk for delirium? What tools can we use to actually diagnose delirium? And then do patients with delirium need a head CT? Now, one of the things the grade methodology does is also assesses what's our evidence. And sometimes, in a sense, I think this is going to be a little bit of an elephant in the room, which is what is the level of evidence for all of these recommendations?
So, the biggest limitation here, which is what led to low certainty in the evidence, is that we don't have high quality, minimally biased ED studies. A lot of the studies had significant biases or were small in size, and therefore lowering our certainty in our evidence. That's not to mean that our evidence is not good. It's just that we don't have a lot of it yet. And keep in
Mhm.
mind that these recommendations are built for the ED. And therefore, when we're depending on evidence, we're depending on direct evidence from the same exact population, which is older adults in our emergency department. As soon as we step out of these kind of like outside of this group, then it's called indirect evidence. It's coming from your ICU population, it's coming from your inpatient population, and so on. And although that does factor in our, general recommendation and kind of looking at this, we cannot just use that indirect evidence to guide our care in the emergency department. And that is the reason that we have a low certainty of evidence, as in the direct ED based evidence. But hopefully, with our continued focus on older adults in the emergency department, we're going to continue to have more and more direct evidence that comes from the realm of our own practice.
So, what's next for the Geriatric ED Guidelines 2.0? What will be the next guideline that the team is working on?
So the next guideline is hopefully med safety, which is coming soon. We hope to a journal near you. Before that, it's coming out for reviews. So if you see it, please take a moment and share your thoughts. And that's another important part of these guidelines, right? Is that they are shared with our stakeholders who are our colleagues, our emergency physicians, our administrators, and so on, to share their opinions and also patient representatives to make sure that we are aligning our recommendations with things that matter and addressing the viewpoints of different individuals that are involved in care.
Well, thank you so much for helping explain and talk through the delirium clinical practice guidelines. We look forward to the next ones coming out, and hopefully we'll be able to have you back to talk about that one soon. Thanks for being a part of GEMCast.
Well, thank you again for having me, and thank you for creating this space for us to talk about this very exciting development and these important guidelines. Delirium is important, GREED is important, and these new set of guidelines are important. So thank you again for creating this space, and I'm so excited to hopefully come back soon.
And if you are listening and you are not a part of the Geriatric ED Collaborative, I encourage you to go to our website, gedcollaborative.com. GEMCast is hosted and supported by the Geriatric ED Collaborative, and you can find a wealth of information there on delirium as well as other topics. And you can make a free account to access all of that freely available information. And we will talk to you next time. Thank you for listening to this episode of GEMCast. You can connect with me on Twitter with the handle @GemPodcast. You can also navigate over to gedcollaborative.com for more resources on the care of older patients.